Good afternoon, everybody. It's lovely to see everyone filtering in. We might make a start just because we've got a jam-packed lineup today. Welcome everybody to the National Centre for Infectious and Cancer lunchtime meeting. Today we'll be talking about the Australasian consensus guidelines for the management of neutropenic fever. And we've got lots of presenters from the different chapters. I'd like to start by acknowledging the traditional owners of the lands on which we meet today. And for me, this is the Wurundjeri people of the Kulin Nation. I'd like to extend my respects to elders past, present and emerging, and my respect to any elders on the call today. And of course, lots of other people meeting from other parts of Australia as well. And internationally. So we'll get kicked off. I'm Dr. Abby Douglas. I'm ID physician and one of the steering group members of this neutropenic fever update guidelines. I'd like to hand over to Nicole Singh, who was also one of the steering members, who will talk through initially the process of forming the guidelines, and then we'll move through to the different chapters. Thanks, Nicole. You're on mute, Nick.
Apologies. Thanks, Abby, and thank you for the opportunity, everyone, to discuss the Principles and Practice chapter of the Consensus Guidelines. As Abby mentioned, my name's Nikhil. I'm an ID AMS pharmacist as well as a steering committee member for the guidelines. I'm speaking on behalf today of Professor Karen Thursky, who's the chair of the steering committee, who's unable to join us today. The Principles and Practice chapter was written by the Guidelines Steering Committee and led by Professor Karen Thursky and serves as an introduction to the following 6 chapters and provides important contextual information regarding the guidelines. And this includes an overall rationale as to why the update was needed, important definitions of terms used throughout the chapters. We also describe the methodology used to develop the guidelines. And lastly, but importantly, describes how to navigate the 7 chapters to find the information you'll be after. So just as some context, the last Australian consensus guidelines were published in 2011. There were 4 chapters, an introductory chapter, as well as chapters on ambulatory management, use of empiric antimicrobial therapy, and use of antibacterial prophylaxis. Notably, there were several limitations of these guidelines that we had noted. Firstly, there were no pediatric recommendations. There was a lack of a consumer focus with no guidance or direction provided on how to approach education for patients and carers. It was Australian-centred. We believe that there should be a scope to broaden this out to include New Zealand. And then lastly, they were outdated. We all know that since 2010, 2011, there have been many new publications which have guided the management of neutropenic fever, which need to be accounted for in the update. So in terms of how we developed the guidelines, we formed a steering committee and had our first meeting in February of 2023. The steering committee comprised of 13 clinicians from Australia and New Zealand, who were either adult or pediatric focused, and it included physicians, nurses, and pharmacists who had a background in ID, medical oncology, or hematology. Importantly, we also included a consumer with lived experience. The steering committee then developed the guideline structure to land on the 7 chapters that we have here. The ones highlighted in orange are new or modified chapters from the previous version. We then went on to generate the questions that each chapter would answer. We formed our writing groups, which by the end included over 50 authors. Our first draft was completed. All recommendations were graded according to the grade methodology, where we provided a level of evidence and strength of recommendation. The steering committee then reviewed all drafts. And then finally, once that feedback was incorporated, it was sent to external stakeholders for review and endorsement, and all of which did endorse them, and we finally got to publication by January of 2026. So this is our navigating figure for the guidelines, and as you can see, Principles and Practice sits at the very top of the figure, which provides that key background information that I touched on. We then flow on to the initial management chapter, which provides advice on the initial workup of a patient presenting with neutropenic fever. Those who are considered low risk can have their guidance outlined in the ambulatory management chapter. Those who were considered high risk, there's further information within the initial management chapter. And then once investigations and things have returned, we have a dedicated chapter on subsequent management. And as you can see, we have sort of separate chapters on antibacterial prophylaxis, antimicrobial stewardship and infection prevention, and patient and carer education, which we'll hear about shortly.
Thanks, Nicole. I'd like to introduce Dr. Gemma Reynolds and Dr. Paul Kinsella, who are both ID physicians involved in steering the or leading the antimicrobial stewardship and infection prevention chapter. Thank you, guys.
Thank you, Abby. Paul and I were delighted to co-lead this chapter, which really looks at an important question that'll be on our next slide that is common to all of us. And that question is really around what it takes to progress someone's neutropenic fever care through a hospital setting. So in a common scenario, someone presenting for their first cycle of RCHOP, which clinicians and what hospital systems are involved in delivering those antimicrobials to those patients. And it's moving neutropenic fever from a single decision around an emergency antibiotic plan to a systems approach within a hospital that really includes not only hematology and oncology and ID physicians, but our pharmacists, our environments and intensive care, our nursing staff critically at the bedside. And so we derived these pillars of whole of hospital neutropenic care just on the previous slide, sorry, Nicole, around antimicrobial stewardship and allergy, the role of clinical microbiology and infection prevention, optimizing PK/PD and the administration of these antimicrobials, and advanced practice nursing. And there's a lot of detail and content within the best practice guidelines, but we're going to canvass between Paul and myself some of the higher level summaries. So in the next slide, we'll speak to the pillars of AMS, allergy and pharmacy. So the chapter details the role of embedded stewardship, so the increased uptake and appreciation of an embedded infectious diseases hematology oncology team to make decisions around neutropenic fever, and ways in which pre and post prescription interventions in immune compromised hosts have been implemented effectively to reduce overall length and exposure of antimicrobials, as well as personalising empiric therapy for our patients. Next, we have details around the validated allergy tools of PenFast and Solfast, and using them in immune-compromised hosts to allow us to access optimal antibiotics that will be outlined in the initial chapter for neutropenic care. And then in the tables, which are, I think, an incredible addition to this chapter, there's really detailed information from our pharmacy colleagues, led by Jason Roberts out of UQ, and Amy Legg, about augmenting antibiotics for renal clearance, hypoalbuminemia and sepsis, particularly around beta-lactams and glycopeptides. And so there's intricate detail in those tables that people may like to review. I'll now hand to Paul to speak to our microbiology and clinical lab correlates.
Yep, thanks, Gemma. I guess the main two topics that we wanted to highlight here were changes or newer evidence in relation to infection prevention, as well as the role of the microbiology lab. So from an infection prevention point of view, what became obvious during the writing of the questions that steered the guidelines was some confusion around isolation of patients and the pros and cons. And on review of the literature, some emerging literature around the negative effects of putting patients in single rooms or isolation. And so out of these, we've generated some general principles on practice for infection prevention, and that includes routine care in positive pressure rooms. We know that there is a reduction in invasive aspergillosis when patients are cared for in positive pressure, while acknowledging that there are a few limitations to this, including that most studies were in the era before mold active prophylaxis, as well as the emerging evidence for psychological harms or increased adverse event rates for patients who are in isolation. Next slide. And so as part of our chapter on the role, or part of our section on the role of the microbiology laboratory, a lot of the recommendations and evidence evolve around two key areas. So firstly is the use of hospital antibiograms for those that are unfamiliar. So these are sort of cumulative susceptibility testing results that are formulated in a way to provide some statistical validity or inform our empiric prescribing guidelines. What's important about these is that they tend to take all comers to a hospital, most of which come through an emergency department, and so they don't consider important patient level factors, so things like whether somebody has neutropenic fever or their degree of immunosuppression. So for that reason, and based on some evidence in the area, we've advised against the use of antibiograms for FEB-NEUT, empiric prescribing specifically, but there may be a role for enhanced or more focused antibiograms. The second area that we tried to address was the role of multi-drug organism screening. We know that patients who are colonized with MDROs have a much higher rate of mortality, and so we formulated some guidelines around what we should screen for and when and how, essentially giving sort of a hierarchy to the different infectious or multi-drug resistant organisms, while at the same time trying to balance the increased resources of both screening and isolation. And so we might move on to the next slide then.
And so really taking these pillars was designed to empower our colleagues who are managing people with neutropenic fever to enhance and optimize these various parts along the journey within a whole of hospital setting. So whether it be addressing the allergy label or stewarding the long-term antibiotics or adopting a risk stratified approach to screening within your unit, we hope that some of the granular data in this chapter can help build those systems within our hospitals caring for neutropenic fever. And I'll hand back to Dr. Douglas.
Thank you. So we have Dr. Sophie Jessup here, who is a paediatric oncologist, aren't you? My apologies, who helped lead the chapter on patient and carer education in neutropenic fever. Take it away, Sophie.
Thanks, Abby. So it was a privilege to lead this chapter along with Liv Smither and the rest of the writing group. So this is focused on patient and carer education with the paper titled Consensus Guidelines for Patient and Carer Education on Neutropenic Fever. So the aim of this paper was to improve communication about the prevention, recognition and management strategies for neutropenic fever. It was written by medical specialists, ID and medical oncology and haematology, allied health, nurses, pharmacists, parents, carers and patients, and importantly had Australian, Aboriginal and Maori representation. And it was written for healthcare workers treating patients with cancer. So the main areas we focused on was recognition, so what to do and where to present when febrile and neutropenic, risk reduction strategies through self-care, basic oral care, environmental exposures, vascular access, device care and vaccinations, management, and this was based on antibiotic choice and duration and antibacterial prophylaxis, an emerging interest amongst consumers, the microbiome and the impact of antibiotics on gut health, and patient education and strategies to optimise education and to make these culturally appropriate as well. So this table really goes through the diet and self-care recommendations, and it's separated into practice points and evidence, so saying when it's low, moderate or high. I've focused on food safety because that's a very common topic that is brought up amongst patients and carers, and really focusing on that move from that terminology of a neutropenic fever to food safety. There's also information on water consumption, hand hygiene, smoking. Next slide, please. Perianal care, visitors, in particular unwell visitors, unwell household contacts, public places and environments with high concentrations of fungal spores. And we also included a section on animals and pets as well, what to do with litter, with bodily waste, and with rodents and animals to avoid. Throughout this chapter, we really pushed a strong recommendation against following low quality recommendations for risk reduction strategies that would interfere with the quality of life of patients with neutropenia. This table talking about basic oral care, and there was recommendations adapted from the MASCC and the ISO, and went through detailed information about dental evaluations, brushing, interdental cleansing, rinsing and moisturising the oral cavity with a focus on avoidance or management of mucositis as well. And comments went to avoid, i.e. thrombocytopenic. The lifestyle measures and recommendations to optimise the gut microbiome was a strong focus of the chapter because of the emerging interest from consumers, and it's now constantly brought up among conferences and seminars. We talked about recommendations and the evidence surrounding it. So recommendations on regular exercise, smoking, sleep, diet, and the more controversial points about probiotics and antibiotics. So this guideline aimed to identify the information required by patients receiving cancer therapy at risk of febrile neutropenia. We really wanted to consider the education and inclusion of paediatric, adolescents and young adults, Aboriginal, Torres Strait Islander and Maori patients, and how to adapt education for culturally and linguistically diverse populations. But we do know that this is an emerging area, and there is for future research and international collaboration required to optimise the guidelines and patient educational tools.
Thank you, Sophie. Some really interesting stuff. I think there's a lot of stuff that hadn't really been explored previously in other guidelines, and it's fascinating to look at some of the lack of support for certain things that we recommend, and as we say, de-implementing some of those is as important as making new recommendations. Thank you so much. I will discuss some of the key points about the initial management of neutropenic fever guideline that was authored by those listed and senior author of Kaspersky. And thank you. Next slide. And essentially just setting the scene, you've got a woman who's just been diagnosed with acute myeloid leukemia, who's has received 7+3 chemotherapy. She's day 9 of this and feels generally unwell, has chills, but no focal symptoms. She is known to be colonized with the carbapenem-resistant Enterobacteriaceae on screening swabs. And she now has fever, a bit of tachycardia and tachypnea. There's really not much to find as far as a source. She does have a little bit of mucositis, and she does have, of course, a tunnel catheter in situ, and she has 0 neutrophils. And so what do we do, and how do we approach this patient empirically in the initial setting? So in the guidelines, we do highlight that a sepsis bundle that is adopted at a local level, appropriate to the institution, is important, because there are a lot of things that should be considered and happen before we even think about which antibiotic. And so certainly the recognition of sepsis is first and foremost. Applying oxygen, ensuring there is intravenous access, which of course there usually is in these patients, but some may not if they're a lower risk patient. Gaining blood cultures both from periphery and central line, a venous blood gas to look at lactate for signs of severe sepsis, and other relevant blood tests like an FBE, UEC, LFTs to assess vital organ function and the neutrophil count. We recommend fluid resuscitation in those who have signs of sepsis, and we did review the literature as far as timing of antimicrobials in this setting, and in adults we do recommend within 60 minutes. In pediatric, the data is a bit less supportive of a strict 60-minute time cutoff, and 2 hours was deemed appropriate based on the literature. Of course, that doesn't end there. You do need to have ongoing monitoring with observations more frequently than would be standard of care on the ward. Essentially half-hourly for 2 hours. If there is an elevated lactate, you do repeat the lactate to ensure that things are improving, and early escalation to intensive care if the patient is not improving or has signs of severe sepsis or septic shock. Next slide, please. So the initial management antibiotics haven't changed hugely, at least from if someone is not in systemic compromise, which is essentially those who don't have severe sepsis or septic shock. So the patient who's got SIRS but not beyond that, we still recommend piperacillin and tazobactam or cefepime, and we have recommendations for allergy, for cefepime for non-severe allergy, and meropenem or a non-cross-reactive cephalosporin if there is anaphylaxis, and recommendations for those who have SCAR. And this is regardless of MDRO risk, so this is for all comers. If there is a concern for abdominal or perineal infection, then we do want to have some anaerobic cover on board. And so if there is piperacillin, tazobactam or meropenem prescribed, then there is no need to change. But if you are on a regimen that does not cover anaerobes, then you would add metronidazole. Now, if there is systemic compromise, signs of severe sepsis or septic shock, and a high risk of multi-drug resistant organism, which I'll go into in the next slide, we do suggest to consider adding a stat of aminoglycoside or an antibiotic that is effective against the MDRO that we know it's colonizing, and or switch to meropenem. If the patient is systemically compromised but is not at high risk of MDRO, there is actually a less emphasis on empirically adding an aminoglycoside and more emphasis on that early recognition, early resuscitation, and early administration of the backbone antibiotic. But certainly, if there is any doubt or there's a lack of surveillance swabs and we're not sure, then certainly a stat of aminoglycoside can be timely and then review in the morning. Next slide, thanks. There's a significant de-emphasis on empiric gram-positive management, so that includes glycopeptides and beyond, because there's no evidence to suggest that it improves outcome in a truly empiric setting. Certainly, if you do have a gram-positive cocci growing on blood culture, pending identification, you may well be justified to add vancomycin, or if someone is VRE colonized, to have a targeted treatment for that. If the patient is systemically compromised and has high risk epidemiology for a resistant gram-positive, and you are suspecting that it is to do with a gram-positive, for instance, if someone is an Aboriginal person, say in the Northern Territory with high rates of MRSA, particularly if there's a concern for line infection or cellulitis, then certainly you would be wanting to empirically cover for MRSA. But otherwise, when we are de-emphasising the need for gram-positive management upfront. And we do discuss in the guidelines about whether if someone is receiving fluoroquinolone prophylaxis in the lead up to their neutropenic fever, do we change the recommendations overall for our empiric management? And there's really no evidence to suggest that we need to change that. Having said that, this is a very small subgroup of patients in Australia typically. Next slide, thanks, Nick. So just I did allude to the fact that we mentioned some multi-drug resistant organism risk factors, and so with gram negatives, it's really the main ones are those epidemiologic risk factors. So that is either if you're in a hospital with high prevalence of multi-drug resistant gram negatives, or if you have been hospitalized overseas in a place where there's high risk of multi-drug resistant organisms, then certainly that person is at high risk of being colonized. If the patient themselves has got confirmed colonization or prior infection with the multi-drug resistant organism, and you'd certainly consider giving empiric therapy. The time limit on when you reach back as far as that screening and is not entirely clear, and certainly if this was a distant history of colonization and had recent frequent swabs not detecting that, then you may well not be so concerned. Other factors are fairly circumstantial, and include things like if you've been exposed to antibiotics frequently and had frequent hospitalizations, which, to be honest, is very common for our patients, but generally speaking doesn't mean they necessarily have high risk of MDRO. There are some MRSA risk factors mentioned there as well, which I alluded to as far as someone who you're worried about high risk of MRSA, and that's outlined in this table. Thanks, Nick. Next slide. As far as we actually have a whole big table about initial diagnostic tests for neutropenic fever. And I think there are a few little things to highlight that may be slightly different from what some people might practice. Certainly blood cultures are the standard of care, and collecting them before antibiotics is essential. The amount of blood you collect is important, of course. As far as other standard lab tests to collect, it really is driven by clinical suspicion. We're moving away from saying everyone because it changes management unless people have a clinical syndrome suggestive of UTI. Certainly, I recommend if there's diarrhea in a patient who's been hospitalised with antibiotics, then we definitely should test for C. difficile because it's higher in our cancer populations and transplant populations. Next slide, thanks, Nick. Also, as far as imaging, we again, move away from suggesting a routine chest X-ray for every patient unless there is a suspicion of lower respiratory tract infection. And in fact, if you are suspecting a lower respiratory tract infection, CT chest is probably a better alternative for that to get you better definition of changes. If there is a suspicion of neutropenic colitis, we do suggest a CT abdomen pelvis. Next slide, thanks, Nick. So now we move on to the subsequent management. So this was what I just spoke about, was basically the first onset of fever and the initial management, the early hours post that. And this really gets to the point of what happens after you've had the antibiotics and given it 48 to 72 hours, you've had time for the cultures to cook, where to from here. And here are the authors listed here who co-authored the guidelines. Next slide, thanks, Nick. So here's a scenario. You've got a patient who, that same patient has, who had AML on 7+3 with neutropenic fever, does have ongoing fever for, despite piperacillin and tazobactam after 72 hours. They don't still have any focal symptoms aside from probably slightly progressive mucositis. And they're a bit tachycardic. They're still very neutropenic. Blood cultures have been negative, and urine was collected in this case, and it was negative. And due to the ongoing fever, they did have a chest X-ray, which was also clear. Now, she does start to develop a dry cough and some pain in her right side of chest, but she does examine normally on her chest examination. And so the questions are, what do you do as far as investigation and management at this point? Next slide, thanks, Nick. So we do lay some ground rules for this chapter because there are a few definitions that need to be clear on what we're saying when we are looking at management and clinical syndromes. And so we talk about what is resolved fever. That's if the fever has settled after at least 48 hours. What is considered persistent fever, which is fever that continues beyond 72 hours of daily fever. Recurrent fever is when a person has had resolved fever, but then for that 48 hours, but then the fever recurs. And that's quite common in patients who have prolonged neutropenia. Targeting therapy, meaning narrowing antibiotics to a pathogen that's been identified on blood or other cultures. Oral switch, of course, is IV to oral antibiotics. De-escalating IVs is when you might have a very broad IV antibiotic regimen and you narrow that IV regimen. And ceasing or discontinuing therapy is when you stop antibiotics altogether. Next slide, please. So basically, we have a very extensive flowchart in the guidelines to try and walk you through the different scenarios of what would happen at the 72 hours of empiric neutropenic fever for these are high-risk patients, essentially. So those with prolonged neutropenia. So the first and I guess fairly the simplest is those who have resolved fever. So the fever has gone away for more than 48 hours and this is a clinically stable patient. And then it's differentiated by whether you've found an infection or not. So if you have a clinically defined infection, which is when you have something like pneumonia or a cellulitis without a pathogen on your microbiology, or if you do have a blood culture isolate, we do suggest that you involve ID, mainly because in these highly immunosuppressed patients, it doesn't always mean that one bug is the entire answer. And unfortunately, patients can have multiple things going on at once. So we do need to have a little bit of thought behind what we're doing and some clinical acumen. Then it depends on whether the patient has resolved neutropenia or not. So happily, if the patient has had resolved neutropenia, they've count recovered, then certainly targeting your therapy to your pathogen is very well supported by ID and is a good stewardship intervention. If the patient has ongoing neutropenia, there is a bit of a caveat here that if you do have significant mucositis, so they're having trouble taking orally, they're often being put on TPN or other replacement, then these patients unfortunately do have often significant, and sorry, NE means neutropenic enterocolitis. So inflammation of the gut, all the way up from the mouth down to the lower intestine. They do have a very leaky bowel wall, and it just because we grow one bug on blood culture doesn't necessarily mean that it's just that E. coli. They've likely got a polymicrobial gut inflammation. So if there's no mucositis or enterocolitis, then it's reasonable to consider targeting the therapy to the bug that you found in the blood. But if there is that significant mucositis, we do suggest to continue broad therapy until the neutrophils recover. If on the middle part of the slide, if there is a fever of unclear origin, we haven't identified a pathogen, and they're still neutropenic, but they don't have mucositis. So they're no mucositis, ongoing neutropenia, but otherwise well. This is the area of the how long study of de-escalating antibiotics to ceasing antibiotics. We do differentiate between allos and non-allos, mainly just because the allo patients, there's not as much data. They were fairly underrepresented in the how long study. So we just make it more of a consider. In the non-allos, it's a bit more of a stronger recommendation, as you would see in the table and the guidelines. If there is significant mucositis and neutropenic enterocolitis going on, we do again suggest to consider continuing the broad therapy as opposed to narrowing. And but of course, if the neutropenia has resolved, you haven't found an infection, certainly you can stop empiric therapy. Next slide, please, Nick. The next slide is next scenario would be, of course, like the patient we had in our clinical scenario I mentioned, is that if they have persistent fever. And then this is dichotomized by whether the patient is stable or unstable. If the patient is stable, we suggest to maintain the current therapy and not to escalate, but we certainly suggest to consult ID, re-examine, collect appropriate microbiology based on clinical suspicion, and then certainly if there's ongoing fever, would consider imaging to look for invasive fungal infection and other undetected infection. The guidelines now suggest either FDG, PET-CT or CT, and the decision to use which depends on access, on whether the patient is clinically stable enough for a PET, and cost, of course, is a consideration. If there is any concern about the CNS, then MRI brain is relevant, and also obviously to consider non-infective causes as driving fever as well. If the patient is unstable, of course, we do support escalating therapy. We do definitely suggest repeating blood cultures because more likely to have a pathogen identified if someone is deteriorating. And next slide, thanks, Nick. So we do suggest about you can consider ceasing antibiotics in patients with persistent fever if it is confidently due to a non-infective cause, but only if you have looked for those other deep-seated infections and invasive fungal infections. So if you've done the scans, the patient is otherwise stable but having fever that we think is driven by a drug or some other non-infective cause, then certainly stopping antibiotics is reasonable. Thanks, Nick. As far as if invasive fungal infection is suspected, which certainly in our clinical scenario of someone with pleuritic chest pain, persistent fever, that is, these are worrying signs. We definitely suggest urgent imaging and empiric change to addition of mold-active antifungal therapy or change of mold-active antifungal therapy if they're already on a mold-active prophylaxis. We don't suggest to add antifungal therapy just with persistent fever without any signs on scans of invasive fungal infection, and support going through a diagnostic strategy. For recurrent fever, so this is the patient's fever had settled, but then unfortunately has recurred. Now, this will depend on where the patient is at with their antimicrobials. If the antimicrobials have already been ceased, you've been excellent stewards and followed the how long study, then it's reasonable to just recommence empiric standard therapy. If the empiric therapy is continuing to be prescribed and they've had recurrent fever on your piperacillin and tazobactam or your standard backbone, if they're hemodynamically stable, we suggest to maintain the current therapy, but definitely reculture and consider imaging. There is some evidence to suggest that in recurrent fever, you're more likely to have a bloodstream infection, so definitely collecting the cultures is useful. And of course, if the patient is hemodynamically unstable, that's a standard thing about adding an aminoglycoside and considering other resistant pathogens and reinvestigating. Thanks, Nick. So other key points that are in the guidelines are, of course, if someone has been commenced on very extended spectrum therapy, such as carbapenems and glycopeptides, whilst we dissuade people from doing that upfront. If it has been commenced, we do give some recommendations around considering to rationalise back to either standard spectrum therapy or remembering the how long approach to consider ceasing altogether. If the patient was unwell at neutropenic fever onset, of course, that's a little bit more concerning for a resistant organism that we just didn't detect. And so that's more of a consider. We do have a good section about duration of therapy for microbiologically defined infections. And so if a patient has a gram-negative bloodstream infection with rapid clinical response and clearance of blood culture, then a minimum total duration would be 7 days of antimicrobial therapy, but that then is beyond that is guided by other factors, including whether we think there's a persistent nidus of infection or a deep-seated infection or a resistant organism. Certainly, you can consider oral switch with a gram-negative bloodstream infection, for instance, an E. coli, if you think the enteral route is adequate. Thanks, Nick. All right, so I've done lots of talking. Now we'll hand over to another author, and I'd like to welcome Joanne Tay, Dr. Joanne Tay, who is an ID physician who helped lead the ambulatory care in neutropenic fever guidelines. Thanks, Joanne.
Thanks, Abby, and everyone for the opportunity to present the ambulatory care portion of this guideline on behalf of my co-authors. Our chapter attempts to answer the question as to whether some patients with neutropenic fever can ever be safely managed in the outpatient setting. In our section, we've included both adult and pediatric clinical decision rules. We've expanded on the infrastructure and eligibility criteria that ensure success of a low-risk ambulatory care pathway, as well as include dedicated guidance, which is new, for oral antimicrobials for treatment of neutropenic fever in outpatients. In the interest of time, I won't be covering the priorities for future research, but I've just listed them here. Just next slide, Nikhil, thanks. So we have identified in our literature review 3 adult clinical decision rules. I should mention in the blue, the Talcott criteria were first published in 1988, so are quite dated and have now been superseded by the Multinational Association of Supportive Care in Cancer, the MASC score in pink, and the Clinical Index of Stable Febrile Neutropenia, the CISNE score, in grey. In the table on the left, you can see the clinical characteristics of each of these scores that are relevant to each of these rules. And on the right, basically just goes through what a low-risk patient is. So with the MASC, someone who scores greater than or equal to 21 or a CISNE score of 0 are considered at low risk of serious medical complications and therefore appropriate patients for management in the outpatient setting. Just if you could click, Nikhil, the MASC score is validated in both hematology and oncology patients with close to 30 publications worldwide, including Australian data. And in contrast, just another click, thanks, Nikhil. The CISNE score is quite new, published in 2015. There's only 8 studies comparing it to the MASC score, and at this point in time, just validated in the oncology setting with no Australian data. On the next slide is some pediatric clinical decision rules in the table on the left. And the one that we chose to focus on in our guideline was the Oz rule, which is a recalibration of the SPROG adverse event rule. It's been validated and implemented in the Australian setting and also internationally. The clinical criteria is outlined in table 3 here, and similarly to the MASC and the CISNE scores, as you've seen, a low risk score is close to 0 or 1, where these patients are generally appropriate for management in the outpatient setting. On the next slide is a case just to illustrate how a low-risk ambulatory care pathway might function in action. So this is Ms. DS, who's a 19-year-old female who lives with her family and is close to the local cancer centre and to the emergency department. She is a university student and ECOG 0, independent with all activities of daily living. Unfortunately, she has a diagnosis of Ewing sarcoma of her right leg, and is receiving monthly cycles that are alternating of vincristine, doxorubicin, cyclophosphamide, and ifosfamide and etoposide. After receiving cycle 7, which is VDC, she presents at day 8 with a fever, 38.5, with no chills or rigors, and is not confused. She's hemodynamically stable when she presents to the department with no real localizing symptoms and no mucositis. Importantly, her neutrophil count is 0.2, despite pegfilgrastim that she receives on day 3 as part of her chemo. And importantly, her blood tests are normal with normal renal, liver function, electrolytes, and blood glucose levels. Just if you could click, yeah, putting this patient through the MAS score, as you can see, she scores 26 and also a CISNI score of 0, which corresponds to a low-risk patient. On the next slide is just some details on key features of low-risk ambulatory programs and benefits. The overarching theme of this chapter was that low-risk ambulatory programs are safe, cost-effective, and can improve quality of life in both adult and pediatric patients with cancer. Both adults and pediatric studies have demonstrated no difference in treatment failure, in mortality, or duration of fever in ambulatory or inpatient care of patients who are designated as low risk. And specific infrastructure requirements that I've included in this table that make for a successful ambulatory program need to include facilities in which to assess, diagnose, monitor, and treat patients who present with neutropenic fever. Once a low-risk patient is identified and scored as per a clinical decision rule, outpatient treatment can be started. Patients then can be ideally discharged home if they're stable, educated on symptoms of concern, and be followed up at regular intervals until clinical and neutrophil recovery occurs. In the event of unexpected clinical deterioration, patients should be provided with timely access to healthcare and be readmitted for reassessment. So that would be in the ideal situation. There are also key safety net or eligibility criteria that we expanded on in this chapter this time. They're now grouped by disease, patient, and neutropenic fever episode-related factors. In the interest of time, I won't go through every single criteria, but simply to say that the scenario that I painted with Ms. DS, she fulfills a lot of the criteria that would make her a good candidate for ambulatory care. And quite a new addition to this guideline on the next slide is a specific recommendation on antimicrobial treatment in the setting of neutropenic fever for adults and pediatrics. We also include dosing guidance that's stratified by the type of allergy status. So we've included severe or non-severe penicillin or cephalosporin allergies. Standard therapy is highlighted here in the purple. So for both pediatric and adult patients, standard therapy is amoxicillin clavulanate and ciprofloxacin. Where feasible, we've also made a strong recommendation that all patients with cancer with suspected or confirmed antibiotic allergies should be referred for formal assessment, ideally before starting cancer therapy, but we realize that this isn't always possible. Another key feature of this particular section was to allow for adaptability and flexibility. The choice of empiric IV lead-in antimicrobial therapy before oral switch was not dictated and should be guided by local antibiograms. And lastly, the duration of antibiotic therapy should also be guided by individual patients and by their neutrophil count recovery and clinical improvement. So to finish, going back to our case, on the final slide, Ms. DS receives empiric piperacillin tazobactam while awaiting preliminary investigations from her septic screen. As mentioned, she fulfills the low-risk criteria for MASC and CISNI, and as she remains hemodynamically stable after some monitoring in the emergency department, she's discussed with the oncology and ID teams and deemed a suitable candidate for outpatient management. She's discharged with a 7-day course of amoxicillin and clavulanate and ciprofloxacin, and her patient and family are given detailed information on how to monitor her vital signs, the frequency of this, and also red flag symptoms. She's provided with contact details for the oncology department should things change at home. Reassuringly, her fevers settle at home within 36 hours of starting the oral antimicrobials. Her septic screen remains negative, and her neutrophil count recovers to 1 by day 5, having received pegfilgrastim. She receives close telehealth follow-up over the next couple of weeks to ensure recovery, and she presents in time for her next cycle of chemotherapy. She also develops other episodes of neutropenic fever in subsequent cycles, and as she scores as low risk for these as well, they're managed in a similar way. So this concludes my section and hopefully highlights how some patients or the right patients can be managed in the outpatient setting. I might hand back to Abby to introduce the next speaker. Thanks.
Thanks, Joanne. Beautifully done. It's my absolute pleasure to introduce Professor Monica Slavin to represent the antibacterial prophylaxis guidelines, which were also led by Julian Lindsay, who sends his apologies away over in the US. And thanks very much, Prof. Slavin.
Thanks so much, Abby, and I hope you can see me okay. Now I'm going to be talking on behalf of the antibacterial prophylaxis group, and this was led by Julie and Lindsay with contributions from both paediatricians, oncologists, and also our colleagues in hematology. So next slide, please. This is a typical case where you might consider thinking about fluoroquinolone prophylaxis, which is what I'm largely going to focus on in this discussion. We have a patient with relapsed AML to receive flag idarubicin induction therapy. Previously, this patient had had severe mucositis and ICU admission with septic shock for an E. coli with extended spectrum beta-lactamase production. And of course, in your hospital and in your unit, you note that fluoroquinolone resistance is relatively common within your institution. And so the question is really, do you recommend fluoroquinolone prophylaxis? But even before that, we would consider whether you would recommend it in a more global scale across your institution for patients receiving inpatient chemotherapy. Next slide. So just going back to the data, what we do know, and this is from a study from the US looking at longitudinal data in multiple hospitals from multiple patients with cancer undergoing chemotherapy, there were really some very clear markers of which patient is at risk for mortality from febrile neutropenia. Of course, gram-negative bacteremia is one, but a very big one is also age and comorbidities, as you can see listed here. And you can see in this slide that with patients with documented infection, and even those without documented infection, the mortality really goes up with the number of comorbidities in the patient. So it's the elderly comorbid patient that we're most concerned about mortality from fever and neutropenia. Next slide, please. We do know that there have been many instances over the years of trying to intervene and prevent bacterial infection in patients with febrile neutropenia, going right back to the days of, laminar flow rooms and interventions with trimethoprim sulfamethoxazole, fluoroquinolones, and enteral decontamination. And so originally, next slide, please, the very first instance of using this and using fluoroquinolones in a prophylactic way, please go forward, there we go, was looking at these studies that were co-published in the New England Journal of Medicine quite a few years ago now, looking at in solid tumour patients and in hematologic malignancy patients, looking at using fluoroquinolone interventions. Next slide, please. So what we can learn from both of these is that, yes, fluoroquinolone in these studies did reduce instances of initial fever and bloodstream infections with gram-negative organisms, but didn't have an impact overall on deaths. And this has been carried through in more recent meta-analyses. So recent meta-analyses over the last several years really do not show an increase risk of death in current circumstances. However, when we go back to the very first one that was conducted around the time of these studies, there was seen a reduced risk of death. And that really led to the enthusiasm and widespread adoption of fluoroquinolone prophylaxis. And you will, find it very frequently used throughout US institutions, based very much on this meta-analysis, but which did have some flaws in that it was looking back over, the previous 20 years. Many of the studies included in this were from, the 1970s, were using Bactrim prophylaxis. And of course, our management of patients with fever and neutropenia has progressed massively since at this time. So I would say that this meta-analysis showing decreased mortality is really not relevant to us in the current era. And those that have been conducted more recently showing no reduction in overall mortality are really more informative and more true to us. So ultimately, we are looking at bloodstreaming, looking at this whole concept through the idea of should we be using a antibacterial prophylaxis in patients who are being admitted to hospital and are being observed and undergoing modern sepsis care. And yes, they do have risks for mortality if they've got multiple comorbidities, but can we manage that within the hospital without using fluoroquinolone prophylaxis? And so we go into the pros and cons very much, and I won't go into all the details about what we discovered, but just to say that on balance, we do think that the benefits of fluoroquinolone prophylaxis for hospital inpatients do not outweigh the risks. And so many of the things we thought about were things like cost, toxicity, drug-drug interactions, flow-on effects from antibiotic usage and for the usage of diagnostic tests, and also, of course, the collateral problems of fluoroquinolones, such as resistance, selection of resistant organisms, and microbiome disruption. So what were our recommendations overall? Overall, we recommend against the use of fluoroquinolone prophylaxis in the inpatients where you do have high scrutiny of those patients and modern sepsis management. We do distinguish, though, for outpatients without timely access to empiric fever and neutropenia, particularly where you may have associated mortality risk factors, as I've highlighted, those elderly patients with comorbidities. And in those patients, we do recommend considering fluoroquinolone prophylaxis. So this is a very kind of tightly defined group who are at high risk, i.e. have prolonged neutropenia, who have comorbidities and are being managed in the outpatients. In any other patients, we recommend against prophylactic antibacterial use. Next slide. Now, this is a very busy table, and we're not going to talk through it all, but this is the table where we actually talk about a decision framework for those patients who are managed outside the hospital, where you would consider thinking about fluoroquinolone prophylaxis. So we've, from the literature, tried to coalesce and present all of the different factors that are indicated to increase mortality in patients who do have bloodstream infections or febrile neutropenia, and take these factors into consideration when you're deciding, is this the patient where I'm going to think about using fluoroquinolone prophylaxis? But we do think it should be a very considered decision, taking into account all of these factors and the balance of risk versus benefit. Next slide. Okay, so that is my section. And I guess we're going to open it up now to Q&A and more discussion. Thank you.
Thank you, Monica. And thank you to everyone who presented so beautifully. And thank you to all who contributed to the guidelines and also contributed to reviewing from a stakeholder perspective the guidelines. It was incredibly valuable input from everyone. I'd like to open it up to any questions or comments from the audience. Please raise your hand or pop in the chat. I'm happy to speak of your question from the chat or also can invite you to speak at the time. While we're giving people time to have a think, I think one we do in the Principles and Practice chapter have a table about the future directions and gaps in knowledge. And I think writing these guidelines really did highlight just how much we don't know and how little data we have to inform some of our recommendations. Things that I think would be a bit of a call to action for people around Australia and New Zealand and the globe, looking at things like how the screening tests that we do inform empiric therapy, in which scenarios, how does mucositis affect what we do and recommend. More data about targeted therapy, in particular, the safety of narrowing in this setting of mucositis or a single isolate like E. coli. And some more data about early cessation of therapy, particularly in the high-risk groups like allogeneic transplant, more understanding about CAR T therapy and novel therapies. And certainly, I'm sure there are many other topics that were mentioned that we do need to understand more about. Sophie, I guess with the consumer and carer chapter, what things stood out to you as far as things that we need more data to support what we tell patients?
I think there's a few things we need more information about. I think the neutropenic diet is still controversial, and I know there was that recent publication about liberalising diet versus a neutropenic diet, particularly in the transplant and leukemic patients. So in some settings, liberalising may not be the best recommendation, but I think that does need more research into what groups we can kind of de-escalate and work on quality of life, because food is a big thing that patients and carers ask about when they're going through quite lengthy treatment journeys. I think the other area would probably be the microbiome. There's still a lot of emerging research and literature in that space, and I think amongst consumers it's been shown to be a big topic of interest. How they can, they always ask what things can we do to reduce the risk of fever neutropenia, and finally there might be some things that are recommended or that they can, and that gives them power and autonomy back to carers and patients and families as well.
Yeah, I agree, Sophie. It's lots to do there, and it's important that we kind of don't restrict too much if we don't have a lot of evidence. Monica, any thoughts and reflections you had on writing the guidelines and gaps and things that we really should try and find more about?
Well, I think there's very little data out there on the use of fluoroquinolone prophylaxis in emerging populations like CAR T cell therapy, and of course in some centres, particularly in the US, it's just standard practice. And we know that during that neutropenic time and where the first fevers occur early after CAR T, for example, it's much more likely to be cytokine release syndrome than to be bacterial infection. I think some of Gemma Reynolds' work in her PhD shows that very nicely. So, we do question this widespread kind of recommendations and adoption that it's really leaked out from these initial 2 studies in the New England Journal of Medicine and a very favourable meta-analysis based on rather questionable data, that has really leaked out to become standard of practice across many different new interventions. And I think we do need more evidence there. And I think, again, something Gemma Reynolds has looked at in her PhD and shown that in our CAR T cell patients in Australia, we do not have more mortality from bacterial sepsis, even though we don't use routinely fluoroquinolone prophylaxis. Our incidence and mortalities are very similar to those overseas where fluoroquinolones are used. So I think we do need more of this kind of data saying, look, is it really necessary that we're exposing patients to these, potentially toxic agents that can interfere with gut microbiome as well, on the basis of very little evidence. Yeah, I think we need more.
Thanks, Monica. One other thing that when we were writing some of the stuff about extended infusions and PK/PD, etc., the recommendations about extended infusion of beta-lactams was another thing that, whilst potentially beneficial in some patients. The practicalities in a person who is on lots of infusions, including perhaps their cyclosporin, TPN, antibiotics, other things, and whether that, you know, you do go for an extended infusion in that patient isn't. I think there are some practicalities and considerations that in the immunocompromised patient we'd have to think about. I'm not sure if Gemma has any comments or thoughts on that.
Yeah, I mean, it's a very challenging space where the BLING-3 trial shows us we are angling towards an absolute mortality difference of 2%, but it wasn't statistically significant in the trial. And so it does become a resourcing and access and logistics question of how much nursing power, time and attention can be devoted to that particular delivery. So our takeaway and also speaking with, you know, pharmacists leading that program and intensivists leading that program is if the setting is resourced and that can be facilitated, fantastic, aim for that 2%. But if it can't be, there are multiple other components of neutropenic fever care that need to be optimized, even more so than antibiotic infusion delivery. We need more data in specific immunocompromised patients. They were not a huge subset of BLING-3, but critically unwell patients gave us that 2%.
Perfect. Thanks, Gemma. I think that's kind of coming up to the end of our session today. So we've really covered a huge range of topics in neutropenia and prevention, management, diagnosis, etc. And really applaud everyone for their inputs into this huge amount of work that took a long time to come together, but we got there in the end. And thanks so much for everyone for their input and for their attention today. Thank you.
Thank you. Thanks, Abby.
Thanks, everybody.